afternoon, esteemed colleagues, members of the federal government, members of the medical community, and the other stakeholders who have joined us for today's insightful discussion on the state of anxiety in Canada, where we will explore existing and emerging treatments. I am Peter Billiard, President and Co-CEO of EmpowerPharm. And before I turn the floor over to our distinguished moderator and panelists, I want to welcome all the 177 attendees. Before we begin the discussion, I would remind everyone that this session is being recorded and will be available to you after the meeting. I would now like to introduce you to the scientific and medical ethos that is the bedrock of EmpowerPharm. Our journey began with a singular vision to forge a Canadian-owned and based pharmaceutical enterprise dedicated to the advancement of therapeutic options, addressing critical gaps in global healthcare. The cornerstone of this vision was the therapeutic potential of a compound that presents a promising pharmacological profile for mental health interventions without the adverse side effects commonly associated with benzodiazepines, SSRIs, and SNRIs. Our confidence was not just in the molecule, but in our capability to attract a team with unparalleled expertise to develop a unique pharmaceutical formulation platform with rigorous scientific methods and clinical research underpinning every step. The empirical journey led to the construction of a state-of-the-art manufacturing facility compliant with good manufacturing standards, ensuring the highest caliber of drug production. The scope of our mission has expanded from the pharmaceuticalization of cannabidiol in a prescription form to the exploration and development of new patentable pharmaceutical entities and the refinement of existing therapeutic molecules. EmpowerPharm has not only conceptualized but operationalized a formulation platform that is currently in the final stages of a phase 2 clinical trial. This trial is a critical step in validating the safety and efficacy of our cannabidiol-based therapy for the indication of social anxiety disorder. We are on the cusp of introducing to the medical community a new product developed in our own facilities and promises to set a precedent for pharmaceutical innovation in Canada and internationally. Our commitment to patient empowerment is unwavering, and we stand ready to contribute substantively to the landscape of mental health treatment. Thank you for your attention and for the role each of you plays in this shared mission. I want to take a moment to thank our co-host in today's panel discussion, Stella's Place. Stella's Place works to provide free, innovative mental health services to young adults between the ages of 16 to 29 in Toronto, Ontario. This includes vital programs in peer support, clinical, employment, wellness, and recovery. Thank you to Stella's Place, and thank you to the Executive Director, Nzinga Walker, for joining us as a panelist today. I would now like to turn it over to our moderator, Dr. Murray Steen. Dr. Steen is a distinguished professor of psychiatry and health and the Vice Chair for Clinical Research in Psychiatry at the University of San Diego. He has written or co-written over 600 peer-reviewed scientific articles on topics such as the treatment of anxiety and trauma-related disorders, including social anxiety disorder and PTSD. He is also the Senior Medical Consultant for EmpowerPharm. Thank you to Dr. Steen for moderating today's forum. Murray, I pass the microphone over to you.
Yeah, thanks. Thanks very much, Peter. I'm happy to serve as moderator for what I'm sure is going to be an insightful conversation today. Needless to say, this is an important topic. In recent years, the prevalence of anxiety has grown, affecting individuals across diverse demographics. It reverberates through our communities, through our workplaces, and most importantly, has an impact on our collective well-being. So as we convene today, we recognize that the impact of anxiety is far-reaching, underscoring the urgency of understanding its current state and addressing the unmet needs in its treatment. It's a privilege to be joined by our distinguished experts and advocates in the field today. They bring a wealth of knowledge and experience representing key facets of the mental health landscape. So today we're joined by Dr. Peggy Richter, the inaugural head and co-lead of the Frederick W. Thompson Anxiety Disorder Center at Sunnybrook Health Sciences Center, where, among other aspects of her job, she heads the sole residential treatment program for severe obsessive compulsive disorder in Canada. Dr. Richter is professor of psychiatry at the University of Toronto, an associate member of the Sunnybrook Research Institute. We're also joined today by Dr. Mary Bartram, the Director of Research and Evaluation with Step Care Solutions. Dr. Bartram has led mental health and substance use policy development and implementation within federal and territorial governments, and she's the former policy director with the Mental Health Commission of Canada. We're also joined today by Nzinga Walker, the Executive Director of Stella's Place. Throughout her career, she's worked to ensure that children, young adults, and families receive effective services that are respectful of people's diverse backgrounds and belief systems, and she works to destigmatize mental health in her work and community. And we're also joined today by Dr. Jitendra Sareen. He's the head of the Department of Psychiatry at the University of Manitoba, in addition to a number of other hats that he wears in terms of the provision of mental health care in the province of Manitoba. Dr. Sareen's research focuses on understanding the underlying mechanisms of mental health disorders, with a particular emphasis on anxiety and depression. So for the purpose of today's discussion, each of the panelists is going to walk us through a brief presentation focused on key aspects of anxiety, and then we'll move into a roundtable discussion. If audience members have questions, please use the Q&A function on the Zoom webinar platform, and we'll do our best to respond to as many of those questions as we have time for. So now I'm going to turn the floor over to Dr. Peggy Richter to walk us through a high-level overview of anxiety disorders. Peggy?
Thanks very much, Murray. It's a pleasure to be here with all of you today. I'll just get my slides up. Are they shown correctly? Great, thank you very much. So it is really lovely to be here with all of you, and I'm hoping in the next 3 to 5 minutes, just give people a very quick sense of the anxiety disorders and the problems that they lead to. So to start off, it's important to keep in mind that anxiety is a totally normal, evolutionary conserved emotion. We all think of it as part of that fight or flight response when faced with an immediate threat. And it is adaptive as long as it's in moderate levels, because it helps us prepare for threats, may enhance our learning and our performance. But when it becomes a problem is when there is no clear sense of a threat or danger. And we begin to think about diagnosing these disorders when the symptoms become functionally impairing, distressing, and are clearly in excess of what we consider reasonable in the circumstances. As a group, the anxiety disorders are the most common mental health conditions we have, actually. So this is from a very large, somewhat older study now, suggesting that anxiety disorders as a group affected about 29% of the population. And in fact, if we do another estimate, which is based on lifetime morbid risk, or the risk of developing these conditions if we all live to a ripe old age, we in fact find that the lifetime risk of developing an anxiety disorder is about 34%, more than 1 in 3 people in the population. So these are really common indeed. Now, there are a host of conditions that make up the anxiety disorders that we deal with clinically. At the basis of many of them are panic attacks, which I think most of us are somewhat familiar with. These are very rapid onset, extreme anxiety and fear associated with a host of physical symptoms, things like feeling short of breath, having a pounding heart, sweating, shaking, faintness, dizziness. And in the hallmark condition of panic disorder, people develop a fear of having panic attacks, and that fear will lead them to be constantly on edge. Associated with that pretty commonly is a condition called agoraphobia, in which the focus is on people having difficulty getting help if they need it, or being unable to escape a crowd in the event that they have the symptoms of their panic attacks. And so these are people that we often think of as quite shut in, claustrophobic being a commonly used term, because they're really avoidant of being around a lot of people, crowds, or empty spaces. We have social anxiety, the hallmark of which is this fear of being embarrassed or humiliated in social triggers. And generalized anxiety disorder, which is that condition characterized by excessive worry. So these are typically ordinary, readily understood worries present to excess, leading to physical symptoms. We also have the specific phobias associated with a variety of ordinary triggers, such as animals, dogs, rodents, heights, closed-in spaces. And then we have conditions which currently are thought of as affiliated with the anxiety disorders, but are characterized in our diagnostic system as somewhat separate or close cousins. So we have obsessive compulsive disorder, characterized by intrusive, unwanted thoughts or obsessions, and repetitive behaviors or rituals. And we also have PTSD, a condition characterized by exposure to horrific traumas of one type or another, leading to intrusive thoughts, memories, flashbacks, or reliving of the experiences of the trauma with heightened anxiety, sadness, and other symptoms. So collectively, these are the conditions which affect so many of us in our daily lives. Now, there's been thoughts that the rate of mood and anxiety has been heightened, and certainly it has gone up if we look at rates compared to 2012, for example, in this data from Stats Canada. We can see that the rates of generalized anxiety disorder and social phobia both more than doubled in those past 10 years. With these conditions individually affecting about 12 to 13% of the population collectively. And there may be a number of factors underlying that, and I'm just going to highlight the top two in the next moment I have. One has been the impact of COVID, which none of us should underestimate. The proportion of people dealing with anxiety still remains significantly elevated since the pandemic than it was previously. We can see this biggest peak in 2020 with anxiety rates or people reporting high levels of anxiety going up from 7% to 23% and now more or less plateaued. And by many estimates, the rates of actual diagnosed conditions remain about double or more compared to pre-COVID. We can see here rates of diagnosed anxiety conditions on an annual basis having gone up from 5 to about 10 to 11% here. We also know that a large part of the population, particularly young people, are very exposed to climate anxiety and really affected by this. This has been an increasing phenomenon we see around the world. Large studies done globally show that this affects all of us, but disproportionately younger people. It's been said that 75% of people living in Canada can currently consider climate change a global emergency. And a very recent survey that came out this year by the Mental Health Commission of Canada suggests that about half of young Canadians, those between 16 and 25, are very or extremely worried that climate change threatens the people and the planet. And just to bring home the clinical import of this, it's estimated that 4 out of 10 young people have this affecting their ordinary ability to function. And a similar percentage see it influencing their future decisions, such as whether or not to have a family. So this threat is not just theoretical, but very much immediate. I think on that note, I'm going to hand it over.
Okay, I think I'm all queued up. Great to be here. Thank you very much to the organizers for the invitation. I'm joining you from the unceded territory of the Algonquin Anishinaabe Nation here in Ottawa, and I'm going to speak to anxiety from a public policy perspective. So in terms of unmet need persists, and it's important to think about this in the context of what Dr. Richter was just speaking about. Despite all the innovations, despite the pandemic and those increases that Dr. Richter was just mentioning, unmet need is what we call in public policy sticky. It doesn't shift very much. And the latest data from 2022 from Statistics Canada puts the treatment gap, and that is essentially the gap, you know, how many people who meet diagnostic criteria, and here this is not just for anxiety, but for anxiety and depression, half of them do not access professional healthcare. And we had very similar numbers from 10 years ago. There are similar numbers in other countries. So why is this? You know, to some extent, because we've seen those increases in anxiety and depression during the pandemic, what this suggests is that actually we are providing more access, but it's just not keeping up. So, you know, the yardstick keeps moving as the burden, impact of anxiety and depression elevated during the pandemic. So in some ways that's good news, in other ways it's bad news. There are also long-standing issues and considerations that affect the treatment gap. One is a lot of people, when asked, prefer to manage their own issues when it comes to anxiety and depression. Sometimes that's a good thing because it's normal and so on, and other times it's something that's of concern because people could really benefit from care that can be available. There are lots of barriers to help seeking too. Sometimes it's stigma, sometimes it's lack of trust in the system. Sometimes it's, I'd like to get help, but I don't know where to look. Other times it's, I'm trying to get help, but I just can't find any. So these are policy issues that we confront. And then there are also issues related to poor system design. Sometimes the way we organize the resources that we do have just isn't really centered around people's needs. And even when people do access care, sometimes it doesn't meet their needs. So we know from some recent polling that 1 in 3 people who do connect to services report that they continue to have some or no needs met from that care. And some of the biggest gaps in the quality of care relate to services and supports for obsessive compulsive disorder. But this is true for anxiety disorders in more generally as well. And when it comes to access, certainly medication access, well, not universal, and a big policy challenge in Canada is outstripped by gaps in access to counseling, which face even greater policy challenges. And many of these are related to our inability to innovate, to advance parity in access to mental health services and supports in Canada. That really, there's some deep parity issues that are baked into health policy in our federal system. And we see this in the way in which the Canada Health Act, which essentially governs how funds are transferred, the conditions for transfers from the federal level of government to provincial and territorial levels of government, that coverage for physician and hospital services is required, but other types of care are optional at the provincial and territorial level. And we see this in knock-on impacts for the non-physician mental health workforce, whether that's gaps in access to regulation or just straight up how much people are paid. And we also see there's perverse consequences for equity, that people who are most likely to have anxiety and other mental health concerns are least likely to be able to access them or to have the money to pay for them. And then finally, just a few policy innovations to watch. Wellness Together Canada portal is an interesting phenomenon that developed during the pandemic, where the federal government actually directly provides access to a range of mental health services and supports for all people living in Canada and all Canadians living outside of the country too, including access to a limited range of live counseling sessions. We also know that just recently in the economic update that GST, HST was removed from access, from psychotherapy and counseling, which should improve access to those services and lower financial barriers. We know in Nova Scotia that there's steps being taken to add psychologists and eventually social workers and other providers to public insurance. And 988 is about to launch in a couple of days, which will provide a single 3-digit access number for suicide prevention and mental health crisis. And that's it for me. Thank you.
All for being here. I appreciate hearing from each and every one of you later today. I'm just going to be giving you from, I would say, from the ground level of what we're seeing as we are engaging with some of our participants here at Stella's Place. And so you heard earlier from Peter that, we focuses on young adults who are between the ages of 16 to 29 years old. And so we really focus from a recovery model, but just making sure that the youth are also driving how they would like to see their treatment prescribed. And so to come to Stella Space for services, you don't necessarily have to have a formal diagnosis, but anyone who is having presenting issues that they feel in that is impacting their life and they would like strategies and support around resolving those, they can just come to us and we will offer those services. So, from here, when you look, you could see, we have about an 80% of the participants that we see at Stella Space are identifying with some form of anxiety. And so we know where many of those symptoms are emerging. We heard earlier from Dr. Rachna just about the fact that the pandemic had a significant impact on this demographic. But part of the other piece too is just young adults seeing their dreams sort of disappearing in front of them. And that's happening because of a number of reasons. We are seeing our young adults who, of course, is impacted by the pandemic, but also many of them, who were in post-secondary institution or may have had job that they were feeling was giving them their path to the dream that they had made out. Those jobs disappeared during the pandemic, or, some of them may not have been able to return to school. And so those are some of the challenges that we've seen. People were able to manage online classes, but when school resumed in person, then that became somewhat of a difficulty for them. And to make even things a little bit more challenging for these young adults, we do recognize that about 67% of the participants that we see they're having difficulty focusing. So again, if you're in post-secondary, that become an impact in terms of your performance level. Folks will not be able to retain their good grade because you're having difficulty, not just focusing, but we saw where there was a 62% in the amount of young folks who are saying they're having difficulty listening. And so these are some of the challenges where people beginning to see their dreams just drift further and further away from them because they're not able to really keep intact in terms of some of the challenges that they're experiencing. And so we have some other stats here. But of course, again, we see where there's a 55% in high level of distress that our young folks are experiencing, and just also in terms of their functionality. These are some really high numbers that we're seeing, as well as we see 69% of the young adults are also reporting that they're having suicidal ideation. We do have a social anxiety program, which really tried to look at how we support our young folks. And so we introduced somewhat of a hybrid model. Sorry about that. And so what we did was our first anxiety program really, after the pandemic, we found that it was really difficult for young folks to come out. And so even though they participated in the program virtually, it was really difficult for them to do a bit of an in-person meeting. And so what we did was decided to do a somewhat of a hybrid model where we really did the program first virtually, but really exposed them to the environment that they were going to be seeing help them to meet the participants, the facilitators who are going to be overseeing these programs, and then gradually introduce them to come into the program. And so what we saw after that was done, we saw like we end up having a 90% retention rate in the participant. So it does show that, you know, there is some psychosocial piece element that you can be adding to these programs that can be helping. Along with that was the mindfulness that allow people to relax as they were, you know, facing these challenges with anxiety. You know, one of the challenges that we had in the Toronto region, of course, that is another challenge for young folks, was just right after the pandemic, we had a number of incidents that occurred on our public transportation. And so because our young folks had to use public transportation as a mean of getting around, then that was even another difficult obstacle for them to overcome. And so this is where, you know, being able to integrate these mindfulness breathing exercise for folks, they were able to use that to sort of regulate themselves as they face these difficulties. But another piece for young folks, particularly in the Toronto region, that is we saw, you know, and this is outside of things like the pandemic that we also saw challenging young this demographic, is the notion of the cost of living. It is just an impact for young folks who just can't afford, you know, somewhere where they can live. And then we are seeing where, you know, the uptake to things like the food bank went up by 39%. And so all of these are factors that will impact how someone would respond sometimes to the anxiety of the normal pressure that they are experiencing. And so we see where folks are just really struggling. And so, you know, these situations, you have to help folks to cope, but also not just cope, but finding other ways how they may be able to respond to some of these challenges that are really outside of their control, but they are necessity that need to be addressed. We really saw some of our young folks just really responding very well to some of the treatment that they're experiencing. As I said before, there was a 80% retention rate, satisfaction rate, which was really great for us to see. So far, what we've also seen is 92% of them reporting that they feel better after with their coping and their mental health after completing the program. And so what we found is that the ability to bring people together allow them to beginning to also feel more comfortable engaging in activity outside of the space that we were creating for them. And so people even beginning to foster relationship with not just staff, but with some of the folks that they did meet in the program, which we thought that was great. But what is significant for us is that we saw a 6 or 7% reduction rate in the emergency room visit, which is really what we are trying to focus on is how do you intercept those visits to the emergency. And so when you are able to provide coping strategy for people in those moments, when they're having such challenges like anxiety attack, panic attack, that is really going to help them go over that bump as they're experiencing that. We also saw 38% said that they felt they have made progress towards their job and career goal, which is not unusual that you would see that, because one program is not going to make people feel like they can start doing employment and programming, but it is a start that you had 38% saying that they feel that way. And some of them also reported that they felt a decrease in harming themselves after completing the program. So people are not only seeking services, but they're seeing where this is helping. I thought what was important for us is that the hybrid social anxiety program saw retention rate, I said, already of 80%, but the satisfaction rate of over 85%. And part of the reason why that occurred was because we did what we call a co-design session with them, which meant that we engaged the participants who were going to be participating in the program in helping us design the program in a way that was going to meet their needs. And so because of that, we saw a really good high success in how that turned out. And for dialectical behavior therapy program, we had an 87% in the satisfaction rate of the participants. And so these are some encouraging numbers just to say, you know, what we are able to support on the ground. But of course, we know there are some folks who are still having difficulty because this is where some folks who may need that combination of the psychosocial plus the medical pieces to support them as they take the journey to the next step. And I'll end right there. Thank you.
Thank you, Marie, and thank you all for inviting me to speak. So I'll talk about current and emerging treatments for anxiety disorders. So in this one slide, I describe the clinical practice guidelines across many of our anxiety disorders. On the left side are the first-line treatments for anxiety disorders, and almost every practice guideline talks about the importance of cognitive behavior therapy. SSRIs or SNRIs as being another option. Most practice guidelines recommend a short-term use of benzodiazepines. And then also an important plug for measurement-based care. The G87 is a tool that is freely available that I use in practice around measuring outcomes for patients dealing with anxiety disorders. On the right side are the second and third line treatments. And the good news is there are multiple options as far as medications and different types of therapies. I really recommend using medications and therapy based on the co-occurrence of other difficulties. So anxiety is often comorbid with other health conditions, bipolar disorder, personality disorder. So it's important to think about the person and the other co-occurring conditions. In some cases, we do recommend long-term benzodiazepines, such as in bipolar disorder and anxiety. Atypical antipsychotics are a very common utilized, like quetiapine and Abilify. And then at times we do use mood stabilizers like valproic acid. I'll focus on some of the things that we're talking about and really discuss some of the solutions to Dr. Bertrand's talk, that we have such high needs in our population and our access to cognitive behavior therapy often is very, very difficult. So this is a team that we've been working with in Manitoba, and our main objective is really to increase access to cognitive behavior therapy with mindfulness as an intervention, both for prevention as well as for treatment of mental health and substance use difficulties. This particular slide is from a facilitator training workshop that we did a number of years ago. So why do we pick CBT? Well, it's the most researched psychotherapy. It is the gold standard for mood and anxiety disorders. And unmet need for psychotherapy is often greater than unmet need for medications. And then it's also important when we think about prevention of anxiety and depressive conditions, CBT has been shown to actually delay or prevent onset of mental health issues among vulnerable groups. The largest study was in children of people with mood and anxiety disorders. So when we think about innovation, we think about technology, but I'm going to encourage you to think about classes as our main innovation method. That psychoeducation format is much less intensive of an environment. People in a class can become socialized to what to expect in therapy, and then can step up. Everyone has been in a class, and not everyone has been or wants to be in therapy. And a lot of our perceived need work has shown that people want to handle things on their own. And what we've found is that people can then self-select into more intensive therapy after the classes. And it's very efficient. Out of 100 people that are referred to our CBT program, only about 40 people, 30 to 40, will actually step up into a smaller group therapy. So you can get a lot more access. And then one of the major barriers as far as accessing care is the impact on insurance. So if you get a diagnosis of depression or anxiety, it could impact the person's insurance, and that might be one of the factors that prevent somebody getting access. During the pandemic and post-pandemic, we got funding as ongoing funding from Manitoba government around self-referred access to CBT classes, which are either Zoom-based or an online self-directed course or an in-person course. These classes are 90 minutes once a week for 5 weeks. The classes can range up to 80 or 100 people. We encourage family members or a support person to join, and we have minimal exclusion criteria, only active psychosis or major cognitive impairment. We've adapted this program over the last decade, starting off as for general adults. With the pandemic, we had huge high levels of burnout, and so we worked with our healthcare workers and as a prevention tool and medical learners. We have an adolescent sample. We've worked with public safety and military veterans. We've also trained community clinics and nonprofits to deliver these services. We've also developed land-based activities in partnership with the First Nations community. And we've also worked with newcomers as well as older adults. One of our teams adapted our CBT material to include living with cancer as a module. And then finally, and most importantly, we have a French version for French Canadians. We've offered training nationally, and we've had a lot of training, of course, in Manitoba, but also trained across the country and a diverse range of backgrounds. And we try to do that training every year. And I'll open it up for comments and questions.
So that's been a really excellent overview of treatment and unmet needs and the state of anxiety in Canada. We'll turn to some questions now, and I want to encourage those of you who are watching this on the web to put your questions in the Q&A box, and we'll try and address them. Question for the panelists. So I know that Dr. Bartram highlighted significant unmet needs and to some extent limited innovation in anxiety treatment. What policy changes or interventions do you think are necessary to address some of these challenges? As for any of the panelists, including Dr. Bartram, if you want to. I know, Jitendra, you talked about some sort of innovations. You want to say a little more about that?
Sure. I mean, I think that, as Dr. Bartram was saying, some of the provinces are looking at ensuring psychology and social work services like Nova Scotia. European countries like UK have the improving access to psychotherapy programs. And I think it's extremely important for our most vulnerable to be able to access the evidence-based psychotherapies. And I think at this point in Canada, some of our policies really don't allow that. So we are about 40 million people. We're not a large province. We've talked about the idea of potentially even licensing across certain jurisdictions, because in order to reach especially rural populations, it's extremely important for us to really synergize. Canada is smaller than California in some ways. So,
thanks. Any of the other panelists?
I just, for me, these policies are really great. And I also just want to reiterate the value in people who receiving the service, also informing how the service is delivered, because how the service is going to get delivered in an urban community will be very different in a rural community. And we also, we when we initially started facilitating, like one of our, I think it was our DBT program, it was our peer supporters who were able to say some of the people who were the first to drop out the group were racialized folks. And so they said to us, maybe we should run groups specific for racialized folks. And so then we ran a BIPOC group. And so then the retention rate was extremely high, 80%, right? But that is not something we would have thought of by yourself, but just because that lived experience voice is embedded in the service, we were able to get those feedback and then incorporate it in the service delivery.
I might just briefly comment. I think we need more initiatives like Dr. Serene highlighted so beautifully in Manitoba. And that there's a lot of evidence internationally that for anxiety, peer support, and psychoeducation can deal with all of those, many of those people in the milder range, which is the majority who first present. So that's a really cost-effective thing, and it would be wonderful if it could be coordinated nationally.
Right, thank you.
I can jump in. Sorry, just
Yeah, sure.
a couple of things. So first, it's a combination of those universal policy approaches like parity and access to public health insurance, but also policies that seek in a very focused way to reduce inequities. And to Ms. Walker's point, we need to listen to people, figure out what they need, and then support the services that actually work with communities that are underserved by existing populations and strengthen their capacity. So, you need that two-pronged approach. I think Sir Michael Marmot calls that proportional universalism or something along those lines. I may have gotten that a little bit off, but really important principle. And then the other thing is the system redesign pieces. So the group that I'm working with now, also very much similar to what Dr. Serene was talking about, promoting a stepped care model, but bridging stepped care with choice to try to make sure that we're offering people a range of options at different levels of intensity, and I'm supporting people to make choices about what fits best for them at any moment in time. So there's policy changes around universalism and around really working with equity, deserving populations who are underserved by existing services, and then also doing more, designing what we do have more intelligently now so that we can provide more choice and give people choices that are earlier on, lower intensity, to improve efficiency across the system. Thank you.
Great, thanks. I'm going to go to a question from the audience. This is somebody who's wondering about the prevalence of adults and youth with ADHD, attention deficit hyperactivity disorder, and anxiety. And it seems that the ADHD population is underserviced and under-identified. Would anybody like to respond to that?
I mean, I can add that I agree. I think that there, even as psychiatrist, I had an assessment recently where I might have missed the ADHD if I didn't ask those specific self-report questions. It is very common. It's also being diagnosed a lot. People are more aware of it. And I think some of the studies have really shown, especially with anxiety, there's a high level of co-occurrence with ADHD. And so when we're thinking about treatment, we really have to think about those things, especially CBT or medications. If somebody has ADHD and anxiety, they might not make it to that individual therapy session. And how do you ensure that we are addressing that?
Peggy, anything you want to add about maybe relationship with ADHD and OCD? Is that something you see?
I think it's certainly out there, and I think we've done a poor job, as Jet was saying, of looking for it, particularly in adults, where I think it's really under-recognized. We do better, I think, with children and youth, but when it comes to inattentive type symptoms, which are increasingly being seen so much now in women, we realize we just don't pick it up because they don't distract others around them, so it's not evident to those around them, and yet they're losing out through that inability to concentrate, which Nzinga was highlighting in her population. And I think we also have to be very careful because some of our pharmacotherapies can exacerbate the anxiety inadvertently if we're not careful.
Great, thanks. I just want to mention one of the attendees is asking whether that we're able to share the recording of this, and we mentioned it right at the beginning, but this is being recorded and it will be available on the EmpowerPharm website probably a little bit after the presentation today. This is a question that I think is probably initially directed towards you, Jitender, but others may want to answer as well, but, given their own experiences. How are you able to organize community capacity building to spread the CBT training to other agencies? And were there challenges with agencies lacking capacity to support the demand, especially for youth?
Yeah, I mean, I think we really kind of utilized an engagement process over a 10-year period. We had small funding that started as a Manitoba Patient Access Network grant from Manitoba government, and we engaged our Mood Disorders and Anxiety Disorders Association of Manitoba. I think Dr. John Walker and the team had been running peer support anxiety disorder groups in Winnipeg for a long time. So there's been a strong interest in cognitive behavior therapy. And I come from India, and in India, trying to make therapy available in rural India, you really need those peer support, and task sharing is a very important piece. How do you make these interventions available? So we've really had that buy-in and interest. And CBT is, and the material that we've developed, it really does allow for people to go forward. So we've had the training, but then we also provide a community of practice support so that people can come and learn. And the other part about the classes is really we've allowed people to take their site and say, well, this is the workflow of the person coming in. You can put the classes in wherever you like. So we're not prescriptive that you have to go in, everybody has to go in to the classes. It goes back to Dr. Bertrand's point is choice, right? And I think Zinga's point as well, that we want to engage. And the 5 classes were really developed based on a QI method. We kept asking from people, what do you want in the classes? And said, well, we struggle with irritability and anger. So then we added a module around that. Then we added a module around sleep. So it was really built based on free resources that are available in Canada. We use a lot of the anxietycanada.com material, and Mindshift is the free app that Anxiety Canada utilizes. There are lots of apps out there, Headspace, I see another question, or Netflix, but we know computer-assisted CBT or some level can help patients reduce, get timely access, but also reduce the clinician time that's needed.
I might volunteer at a lower level, and I don't think developing the same degree of training or anywhere close that Dr. Serene's initiative is developing. We have in Ontario something called ECHO Ontario Mental Health. ECHO is an evidence-based hub and spoke technology-assisted model of training intended for primary care practitioners to learn about how to better manage chronic or severe illnesses. And so in Ontario, we have had this supported by the government for about 10 years. I believe there's close to 30 ECHOs now running in Ontario, one of which is ECHO OCD, which just finished its, I believe, 5th year, or 6th actually. No, 5th. Anyway, training around 350 healthcare professionals. So these are weekly sessions. They attend by Zoom. They can do a 6-week boot camp and a 10-week more intensive training in CBT. It is still a light training compared to the depth of skills needed for managing people with more significant illness and comorbid illness. I think you really need the kind of model that Dr. Serene's developed so beautifully. But for lower levels of capacity building, at least for recognition and initiating, it can work really nicely.
Mary and Zinga, anything you would want to add?
Sorry, I was just gonna say, yeah, totally, in agreement with the two previous speaker. And I know when we develop our program, as I indicated, really have the participants designing the program in a way that's going to meet their needs. But the other piece for me is just letting folks know that we do that training for service providers. And so for us, it's not about keeping the knowledge to ourselves. It's also just strengthening the capacity so that participants are able to get the service they need in a broader spectrum of way, just making sure that accessibility to service is being enriched in the sector. So anyone who, from an organization perspective, would need more information, they can always reach out to Stella Space to hear how we provide those services.
Thank you. And Dr. Bartram?
Yeah, I'm just thinking as I'm listening, there are so many great examples of excellent innovation and capacity development initiatives. There's tools about so many different types of models. There's hubs, there's frameworks for knowledge mobilization, and yet somehow 50% of people who need access aren't getting connected. So it's great to talk about what we're doing well, but clearly we need some way to turbocharge that. I don't know that 100% of people who meet diagnostic screening criteria for anxiety should be connected to care, but it should be more than half. And so the policy issue, I think, is how do we leverage the capacity we have to strengthen it's really capacity to strengthen capacity of community services and different parts of the system to provide care all along the continuum. How do we double that? What's standing in the way? And I think it goes back to some of these discussions around stigma and parity, and there's gaps and inequities in funding that go back a long time. So we kind of almost need to work twice as hard. And we've seen just to catch up. And we saw this during the pandemic, lots of explosions in innovation and access to mental health care and substance use health and addiction care as well, I would add. But they were great, but they didn't go as fast as we went in healthcare. And so it's this thing around we've done a lot, and maybe this kind of fits with, actually we've expanded access. It's just we haven't been able to keep up because need has grown. So not quite sure what the prescription is for resolving this, but I guess I just didn't want us to lose sight of the fact that despite these innovations, we're still missing a lot of people.
Yeah, and I mean, it was great to hear about the innovations that are happening. And I mean, I guess one last question I have for the panelists is, to what extent do you think, I mean, part of the issue is I think everybody agrees, is that there just aren't enough services, there aren't enough mental health providers, but can we be doing a better job of matching people to the level of care they might need and want, so that we're not sending somebody to see a psychiatrist when they don't need to and may not want to. And I've seen these kind of things sort of create log jams and sort of inappropriate use of the services that exist. Any thoughts about that, or how we could fix that?
Yeah, I mean, I think when we look at the epidemiology and look at the math and say, well, 30 to 40% of Canadians are dealing with an anxiety difficulty. So we certainly can't have individual therapy of 12 sessions for 40% of the population. So that's where the idea of innovation has to be there. How much, and Dr. Steen and I have done some work around this, around maybe like blood pressure. People have rises in blood pressure above, and then they come down and don't need an antihypertensive for a long time. Similar idea with anxiety. It might rise, come down, and we might not need to have some people go forward. And this whole idea of perceived need and unmet need, that's Stats Canada has done quite a bit around. So I don't think we'll ever have individual therapists for 40% of the population. So we have to look at how do we, and this is why we went with a class-based model, and we're not the only people that have done that. In the UK, they have a 6-session stress control model, which is up to 100 people that go in, they manage the anxiety, and then they could step up into so we want to get people access to care at a timely point. There's also some evidence showing that if you delay people getting access, then they're less likely to recover. Some nice data from improving access to psychotherapy. So it's this idea of severity and timing, and how do you get people the right care at the right time. So
Peggy, you had your hand up, I think.
Yeah, I couldn't agree more. And I think that's where that stepped care approach is so desperately needed on a national basis, ideally. Like Dr. Serene mentioned, the NHS in the UK did it beautifully. A lot of guidelines that have come out in the last decade or so all emphasize the need for step care and how ideal a step care approach is for anxiety, because so many can be helped with those lower level interventions. I think as well, the fact that we have real inequities in access, because so much of what people access is private currently, because our healthcare system only funds a very small proportion of mental health care providers. It's a real problem. And I also heard, I think Jit mentioned the issue of barrier being licensing, which is another craziness, that professionals need to be licensed province to province. And so we may have a surplus of practitioners in some areas of the country, but people in the others can't be served by them.
Great. Well, I want to thank all of the panelists for the great presentations and discussions. And I'm going to turn things back to Peter to just let us close out.
Thank you, Murray. I'm actually going to pass the microphone to Aubrey for some closing remarks. Now, before he does that, I would just like to thank everybody for an excellent forum, and to all the attendees. And just to reiterate, the presentation will be available on EmpowerPharm.ca if you go to our website shortly after the meeting. It won't be instantaneous, but it will be shortly after the meeting. So Aubrey, over to you.
All right, Peter, so thank you very much. As we conclude this enriching panel discussion to a close, I'd like to wish my heartfelt gratitude to Dr. Steen, our eminent moderator, and the collective efforts with Stella's Place, along with other panelists, Dr. Richard, Dr. Serene, and Dr. Patram. This symposium has not only been illuminating, but also a true testament to the strides we are making in the realm of mental health and anxiety. Today, EmpowerPharm is not just as a beacon of innovation, but as a thought leader in the dynamic discourse of mental health in Canada. The unveiling of a prescription CBD heralds a promising horizon for those suffering with anxiety, marking a milestone in patient-centric care. EmpowerPharm's vision is laying the foundation for future collaborations along with the supply chain. Our dialogue is to bring policymakers, advocates, patients, and mental health care professionals together in a confluence of ideas and shared aspirations. We leave today with strengthening ties, a deeper understanding of our collective role, and the impact we make in combating anxiety. EmpowerPharm stands firm in its commitment to be at the forefront of strategic responses to mental health challenges. In unity, we forge ahead, not just in anticipation of what the future holds, but with a conviction to shape it. Together, we are not just observers, but active participants in this journey towards a healthier, more resilient society. Thank you all for your invaluable contributions. May we continue to empower lives one conversation at a time.
Thanks, everybody.